My name is Trinh Mai. I'm the Senior Authorising Officer of the Restrictive Practices Authorisation Scheme in South Australia. Today, I have the wonderful task of talking about the role of social workers in supporting people with a disability and reducing and eliminating restrictive practices. I'm one of 5 social workers in the Restrictive Practices Unit, along with Michelle Zubb, Lisa Henderson, Janelle Fitzpatrick, and Nicola Hunt. Social workers drive change in the conditions around a person that contribute to their inclusion and engagement and provide them with the tools that they need to be the best versions of themselves. The mission statement of the Restrictive Practices Unit is see the person, see the practice. Social workers see the person and see the practice in the context of the systems around people, their families, their friends, their kin, their community and immediate environments, their home and neighbourhoods, sports clubs and teams, places that are too small to be seen on any map, but are the contexts that shape and influence them, their workplaces, their support services, their churches, health services, doctors, their context of popular culture, media and dominant ideas, the social, economic, legal and political systems around them. Anyone who thinks that these things feel too nebulous and intangible has not been an NDIS participant or provider when a new political approach changes an NDIS rule or legal judgment changes what might be considered reasonable and necessary. What isn't obvious in this diagram is the dimension of time. These ecological systems are not frozen in time. They exist in a context of change over time as we as a society change our understanding of the world. Social workers are therefore well placed to understand disability as the result of the interaction between people living with impairments and an environment that is filled with physical, attitudinal, community and social barriers. Our role as social workers is to change those environments around people and to empower them with the tools that they need to participate in society on the same basis with others. The most important tool that social workers bring to any situation is the social work lens, seeing the person and seeing the practice in the whole system. This lens allows us to understand what we are seeing and situate it in its context. Let's turn this lens towards food-related behaviours and restrictive practices related to food. Every year, the Restrictive Practices Unit receives requests for environmental restraints to lock a fridge or a freezer, a pantry, a kitchen, restricting access to junk food and caffeinated drinks. The behaviour support plans told us about people who gorged food until they threw up, who took food from members of the public and from stores, who ate rotten food from the bin, or who drank alcohol until it caused brain injuries, who hoarded food in their bedrooms and hurt staff who tried to limit them. These behaviours are real, and the risks related to these behaviours are real, and that's why restrictive practices are requested. But let's take a step back to 1966 to an architect in the Public Buildings Department called Joe Craig. Part of Joe's role was the development of the Strathmore Centre, a new purpose-built facility to transfer 600 people with intellectual disability who were at the Parkside and Northfield mental hospitals. This was a recommendation from the Cramen report to separate people with disability from people with serious mental health conditions, including those who had committed serious offences. Let's revisit this moment in time. This is the old Adelaide Lunatic Asylum as it was known then, circa 1900. These are the doctors and the allied health staff who worked at the facility. This is the children's dormitory and the men's wards, the women's wards. This is an early music therapy session. occupational therapy workshops for the residents, an occupational therapy workshop with the women's group, the chief's physiotherapist, early pharmacists. See the little vials of diazepam? These were the sketches for the early Strathmont Training Centre and the villas there. This was the school. Buildings as built, and the signage upon its closure. In 1966, Joe Craig described the deplorable meal preparation arrangements at Parkside Mental Hospital, where more than 1,000 people were fed in unison. He said, the meal had been prepared some hours before it finally shuddered along the path to the dining hall, possibly to be put in another heated chamber to be kept for the final half an hour or so before being presented at last for someone to eat. By that time, the food had been pretty well vibrated out of all recognition. It had probably lost its temperature, it had certainly lost its taste, and it was of no interest to anyone except the absolutely ravenously hungry. To address these appalling conditions, Joe Craig designed the large-scale frozen food catering service for the Strathmont Centre, and it was the first of its kind for large residential centres in Australia. The food was prepared, cooked, pre-plated and deep frozen using liquid nitrogen at Parkside and delivered to deep freeze at Strathmont and microwaved when it was actually needed. This system signified a huge leap from the food that was available at Parkside, but there were still limitations. As all of the food was supplied in 2-week increments, the food choices were limited, as were the adjustments for the dietary requirements. Food was pre-proportioned and pre-plated, meaning that there was no ability to have more food if you were feeling hungry or had different calorie needs than the person next to you. Some people were restrained during the meals as standard practice to manage the task of feeding large groups of people with very different needs. Residents were reportedly provided with 20 minutes to eat their meals or it would be removed, a challenge for people with impairments to their fine and gross motor skills and their swallowing capacity. In this context, we can see why some people would develop food stealing behaviours, hoarding behaviours, gorging behaviours, behaviour escalations at meal times, compulsive eating of preferred foods when they had access to it, and highly restricted food preferences in terms of tastes and textures. In the Restrictive Practices Unit, we still continue to see people who have food-related behaviours that are not inherent to the person, but they were the ordinary and expected responses to the circumstances around the person. The system created these behaviours. In this situation, today's care teams are Joe Craig. They are striving to create a system that is better than what has been. They structure meal preparation, food routines, portion control, healthy eating charts in a way that is better than what this person may have experienced in the past. But they also use restrictive practices that will continue to shape this person's behaviour. The social work lens reminds us that what we do and the impact that we have on our clients unfolds over time. The children who experience food restrictions today will experience the outcomes of those practices in the years to come. So our job is to minimise the unintended consequences of our practices today. The Parkside Mental Hospital became Glenside Hospital in 1967, and the Strathmont Centre was shut down in 2017. But we still see the impacts today. The past is never dead. It's not even past. The social work lens allows us to examine the way professionals, systems and governments respond to culture and culturally bound behaviours. For Aboriginal people with disability, the interpretation of cultural behaviours and the pathologising of cultural behaviours is a further experience of marginalisation and disempowerment. And one of the most eminent clinicians in Australia working with Aboriginal culture-bound behaviours is Dr. Tracy Westerman. I'm going to caveat this part of the presentation by stating very clearly that I am relaying the cultural expertise of Dr. Tracy Westerman and her Aboriginal research participants that she documents in her paper, Culture-Bound Syndromes in Aboriginal Australian Populations in 2021. This is not my expertise, and I encourage every person in this room to read this paper as an important step for clinicians and practitioners to see the Aboriginal person and the Aboriginal practice in its context. Aboriginal communities have long recognised culture-bound conditions as being an inherent part of the culture. Aboriginal people who present in contexts that are foreign outside of this cultural context may appear more agitated and distressed. The concept of shame in the presence of non-Aboriginal authority figures has also been cited as a factor impacting on the clinical presentation of Aboriginal clients. Difficulties with communications and language barriers may also mean that Aboriginal people may find it difficult to communicate distress. Professionals who cannot recognise this distress are less likely to empathise and respond in culturally appropriate, culturally safe and culturally competent ways. This plays out in several ways in the Restrictive Practices Authorisation Scheme. Very few people who have worked with and walked alongside of Aboriginal people would question the importance of country, of being on country and being connected to country. And Westerman describes that people who are away from country, their place of birth and their dreaming for extended periods of time may experience symptoms such as physical ill health, including weakness, nausea, general sickness and somatic complaints, spiritual ill health, cognitive disorientation and dissociation. In behaviour support plans, we see this described as behaviours of concern that create a risk of harm: agitation, aggression, withdrawal, absconding, wandering, and failure to comply with house rules. The Restrictive Practices Unit is asked to authorise locked external doors and restricted access to community for Aboriginal NDIS participants for wandering, when what we may be seeing may be a deeply rooted need to be on country and to be walking on country. Those environmental restraints have an impact on all people, but for a culture where the deep connection to country is a fundamental part of well-being, the impacts on Aboriginal NDIS participants is all too clear. Westerman's research participants also spoke of culturally sanctioned activities and behaviours which from a mainstream perspective would appear as self-harming, but were rites of passage or ceremony, such as sorry cutting for grief. Sorry cutting involves cutting or hitting oneself with rocks, sticks or other sharp implements. The research participants identified that the open and intense expression of sorrow enabled resolution of grief to occur with community support and care. These rituals exist as displays of respect for the deceased. Participants also agreed that time was not a consideration in the expression of grief. It wasn't uncommon for relatives, both distant and immediate, to cry at the mention of a deceased person who may have passed away years previously. So how do we as practitioners separate self-harm that may constitute a behaviour of concern that creates a risk of harm that may warrant the use of a restrictive practice to restrict access to sharps, from a culture-bound behaviour of cutting to express deep sorrow, deep respect and deep connection to the person who has passed? We can only do this by acknowledging that what we see in a behaviour may not be what the behaviour means and what the person is trying to tell us. We can only do this by seeking to understand from the person themselves, their family and their kin, what this behaviour may signify in this context. We cannot do this without Aboriginal voices and Aboriginal insight and wisdom. Lastly, Westerman and her research participants spoke of examples of Aboriginal people experiencing visits from loved ones following their passing as a normal aspect of grieving. Participants noted that spiritual visits were predominantly visual, but visits may also include hearing and touching loved ones who had died. It was common for multiple voices to be heard and for these voices to manifest as a running commentary. Participants also noted that with cultural grieving, spiritual visits should also be comforting to the individual. However, this is often dependent on whether or not the grief is concluded culturally. In instances where something may have been missed in the grieving process, visits could take on a troubling or distressing form. From a purely symptom-based perspective, there are clear similarities with clinical disorders like psychoses or schizophrenia. And notably, Aboriginal people have the highest rate of psychotic illness of any group in Australia, experiencing psychotic illness at 1.8 times that of non-Aboriginal people, and they are hospitalised at 2.4 times the rate. So the question that the Westerman research asks is, how many of these symptoms of visual and auditory hallucinations are a misdiagnosis of culture-bound behaviours and experiences? Are we pathologizing and medicating experiences based on not seeing the person and not seeing the practice in its cultural context? I am not speaking in the abstract. In the Restrictive Practices Authorisation Scheme, we've seen the use of restrictive practices and environmental restraints to lock doors and restrict access to community, where it is clear that the behaviours that are called wandering are signs of an Aboriginal person who needs to be walking on country. We see cutting behaviours in the context of deep loss and grief, with no exploration of this context when the restrictive practice of lock sharps is identified. We see psychiatric records of people treated with antipsychotics and benzodiazepines because of visual hallucinations of a person who had passed. The social work lens in these situations guides us towards curiosity, towards seeking cultural input, towards exploring cultural context, and it should guide you too. Lastly, the social work lens recognises gendered and ableist responses to behaviours, and it recognises that as a society we respond to people with disability differently, and we respond to women's sexual behaviours very differently to how we respond to men's sexual behaviours. In the Restrictive Practices Authorisation Scheme, there are times when NDIS participants have unsafe online interactions with predatory people who seek to exploit and prey on them. This may involve financial abuse, sexual abuse, and physical abuse. The risks are real, but the behaviours of concern may not be the behaviours of the person with disability. They are interacting online the way that many people interact online. The behaviours of concern are the behaviours of people who are in the community who seek to prey on others. But the responses are focused on restricting the person with disability. It is to prevent people with disability from accessing the community, from using social media, electronic devices, and the internet. It is to impose curfews about when people with disability can go out and who they can see. Again, the risks are real and the intent to protect is real. But the social work lens questions why we seek to use our statutory powers on the person who is victimised and not the perpetrator. Why we seek to restrict the person with disability rather than taking action against those who exploit and prey on people with disability. When we look at the intersectionality between how we respond to people with disability and how we respond to women, we see a curious situation. We see the restrictive responses that are focused on the person being preyed upon, but we also see women with disability not being permitted to engage in behaviours that might be common in the community. Posting a revealing image of themselves on social media, sending nudes to someone they're flirting with, having sex with someone they met online. The use of restrictive practices and the use of government power is more likely to be used to manage women's sexual behaviour than men's. This is not a new phenomenon. In 1988, the Department for Community Welfare analysed its use of therapeutic safekeeping orders confining children in care to their premises. They found that while the orders were used for both males and females, they were used for different reasons. Males were confined to prevent them from engaging in dangerous drug-taking behaviours, and females were confined to prevent them from engaging in dangerous sexual behaviours. In the Restrictive Practices Authorisation Scheme, the same gendered divide occurs. While male and female NDIS participants may be restricted due to sexual behaviours, women are more likely to be restricted when they are not the person engaging in sexually abusive or offending behaviours. They are more likely to have restrictions on who they can see, their access to social media and devices, and their access to the community. So if the social work lens allows us to see the person and see the practice in the whole system, what are the social work strategies and interventions that reflect this lens? The Restrictive Practices Authorisation Scheme commenced in 2022, and at that time we saw many plans that set out behaviours of concern, the proactive and reactive strategies suggested to address these behaviours, and the restrictive practices required to minimise or prevent the risk of harm. More than 3 years later, we are still seeing some plans that are focused on describing the person with disability and their behaviours. As social workers, the plans we love to read are the plans that see the person and see the practice in the whole system over time. This means that the plan sets out what strategies have been implemented over the past year, what was successful and what was not, what strategies were tweaked based on what worked and what didn't, what changed for the NDIS participant over the past year and what changed in them. What can they do now that they couldn't do before? What skills and abilities have been lost and why? What behaviours increased in the past year and what behaviours decreased and why? How well did the systems around the NDIS participant work to support them? Did they communicate well? Did they share information? Did they implement strategies consistently? What efforts were made to build skills and abilities in the NDIS participant, their family, their support workers, and their care team as a whole? What were the barriers that the NDIS participant faced, and how did the care team help them to navigate those barriers? How did the practitioner and the care team actively support the participant to move forward in their goals? These plans don't have to be the plans that have the best outcomes, but they are the plans that let us know the practitioner and the care team understand their role in the ecological system, that they have the ability to influence and shape the outcomes for people with disability in a very meaningful way, even when there are setbacks. In the Restrictive Practices Authorisation Scheme, there are two kinds of reduction and elimination plans that we see that are not effective in reducing and eliminating restrictive practices. The first states that chemical restraints are determined by the prescribing doctor, and therefore the doctor will decide when to reduce or eliminate the medication. The second states that the reduction and elimination of restrictive practices is dependent on the outcomes of proactive and preventative strategies. Both of these kinds of plans fail to see the person and the practice in the whole system. The first sees the role of the doctor in isolation from every other part of the system, as though prescribing doctors make clinical decisions in the absence of any understanding of the person with disability, their cultural context, their broader care needs, changes to their living arrangements, and their support teams. That prescribing doctors somehow are not informed by the professional judgments of pharmacists, dietitians, OTs, physiotherapists, social workers, psychologists, and developmental educators. The second type of plan seems like it makes sense. Proactive and preventative strategies do have an impact on behaviours and the use of restrictive practices, but it doesn't provide clarity for the care team about how they actively fade out restrictive practices. And in the absence of clarity, systems stick to the status quo. As social workers, we recognise the cognitive barriers and biases that get in the way of successfully reducing restrictive practices. These barriers are reflected in fade-out plans with unreasonable behaviour expectations. The restrictive practice will be reduced if the person demonstrates 0 incidents of verbal aggression and swearing for a 12-month period. I have already failed that threshold today. Most of us will fail that threshold in a year. So why do we hold a person with disability to a standard that we do not hold anyone else in the community to? Unclear standards. The restrictive practice will be reduced when the practitioner and the guardian deems that it is safe to do so. But we don't know what is meant by safe. Shifting standards. The restrictive practice will be reduced when the person does not demonstrate any physical aggression resulting in damage to items for 3 months. This is better. There's some clear objective indicators there. But there was that incident where he threw the item in the 4th month and it could have smashed, but it didn't. But we better maintain the restrictive practice just in case. Circular thinking. We aren't seeing the behaviour because of the restrictive practice, but we can't remove the restrictive practice because of the behaviour. The best reduction and elimination plans are the ones that give very clear, objective indicators of what we will see that will trigger the first stage of reduction and what that stage of reduction will look like. From a positive behaviour support perspective, it looks like the way that we show predictable and consistent responses. When we see this, we will do this. It's clear, it's objective, it's accountable, and it's meaningful to the person with the disability. It recognises that behaviour interventions have to occur with the care team as much as they do with the person with disability. It also provides reassurance for family members and legal guardians who may be genuinely fearful about reducing and eliminating restrictive practices and may seek to have restrictive practices because they may not know of alternative ways to keep their loved ones safe. Many family members and legal guardians are afraid of situations where restrictive practices are removed without warning and without support, and we can understand this fear. Being able to contribute to setting objective indicators to reduce restrictive practices and contribute to identifying that first stage of reduction of supports a care team to have a shared understanding and a shared goal. This form of consensus building and framing of goals is a core strategy of social workers. I'm going to make a bold statement, and that is that social work as a profession has a much greater understanding of institutional power than any other discipline. We recognise the role of governments and organisations in holding power, in using power, and the effect of that power on people with disability, on Aboriginal people, on women, on migrants, and on the aged. We recognise the positional power that we hold as a state regulator, the positional power that you hold as organisations and professionals, the positional power of support workers, even if sometimes we feel powerless. So when we are discussing the consent of an NDIS participant, their free choice, the extent to which someone seeks to access a thing that they're restricted from, we as social workers are much more curious about the role of institutional power. Let's go back in time again, this time to 1961, when William Cramen, he of the Cramen Ward fame at the Queen Elizabeth Hospital, handed over the reins of Enfield and Hillcrest Hospital to Bill Salter as superintendent. Bill Salter recalls that William Cramen took down all the fences. He took the bars off the windows and declared that Northfield was going to be an open hospital. And the worst thing of it was that he also said, and you're going to be superintendent, which meant that he was going to take his hands off it and leave it to me. I had an awful time for a few months explaining to staff why we'd reversed our policies on so many things, because suddenly many of the policies were blown sky high. Bill Salter recalled the response of the new policy of not locking the doors. He said, "So one morning the doors of one ward were left open and the staff waited to see what would happen. Nothing did. The patients went on as though the place was locked up. One patient was seen to come and stand at the door and look out. He put his head outside, but he kept his boots well inside the boundary. He just could not get himself to go out. Another patient complained to the charge nurse that one of the nurses had really gone crazy and left the door open. This is the power of the institution that goes beyond people's objective experience of whether or not they can leave. This is institutionalization that may make people feel safer, feel their world is more predictable when they have the doors locked, or the bed rails up, or the sharps removed. Social work practices in these situations are the practices that reflect the positive demonstration of choice and the positive support of choice. When we see a behaviour support plan that says that the person has never chosen to leave, we cannot tell if this is a positive choice or whether this is the effect of institutionalisation. We don't know if the practitioner and the care team can tell the difference for this person. But we also see behaviour support plans where practitioners develop social stories that let people with disability know they can go outside whenever they want. They develop visuals that the person touches to let staff know what items they want, and this is honoured each and every time. They have records that reflect the implementation of these social stories and these visuals and how they're being used regularly. They have logbooks that show the days when the person has told their worker they'd like to go out, and the workers support them each and every time. In these situations, we know that the practitioner understands institutionalisation and the effect of power. This practitioner knows how to demonstrate true choice and control by an NDIS participant. As we come to the end of this presentation, I want to return to where we began, with the Ghana people who brought nations together through dialogue, relationships and understanding. And that is our task too, to facilitate not just services and supports, but genuine understanding and change across systems, to see the person and see the practice across the whole system. The work of social workers in supporting people with disability is not just about reducing behaviours of concern or restrictive practices. It is about recognising the long echoes of history, understanding the influence of institutions and challenging the systems that carry these legacies of control and exclusion. The social work lens helps us to see these forces clearly, not just in the past, but in the here and now, in the ways that support is provided and in the decisions that are made every day in people's lives. We've seen how food-related behaviours may have their roots in deprivation, institutionalisation and control. We've seen how self-cutting, wandering and spiritual visitations, when understood through a Western biomedical lens, are too often misread, misdiagnosed and pathologised, rather than being recognised as deeply cultural, deeply human responses. And we've seen how gendered power dynamics may shape responses to sexual expression. Social work is a mirror, reflecting back to us the values, assumptions and power dynamics that underpin our work. It reveals the extent to which our systems are still operating on reactive, deficit-based and often protectionist models. But it also reveals the brilliance, the compassion and the ingenuity of professionals who are deeply committed to seeing the whole person. This work is not easy. You are navigating complexity, risk and resistance every day. You are balancing the safety of individuals within funding constraints, workforce shortages and layers of red tape. But in the midst of that, you're also doing something extraordinary. You are Joe Craig, trying to build something better than what has been. You are Bill Salter, opening the doors and supporting people to step through when they are ready. You are the practitioner who develops a behaviour support plan, not through a template, but as a tool for change. What we do in this space matters. The way that we develop behaviour support plans matter. The clarity with which we describe reduction and elimination matters. The conversations that we have with people with disability and their families about fear and hope matter. The work of social workers and of all allied health professionals matters. It matters to the people whose fridges are locked, to the people whose devices are taken away, It matters to people whose culture is misunderstood. It matters to the children who will become adults under systems that either nurture them or diminish them. Padniadlu Wadu. Let's keep walking together. Thank you.